Well, hello once again. Very warm welcome to the August episode of Discussing RA. It's our rheumatoid arthritis podcast series where, as ever, we're going to bring you up to date with the very latest research and publications in the field of rheumatoid arthritis. And there's no better field. My name is Ian McInnes. I'm the head of College of Medical, Veterinary and Life Sciences and the vice principal at the University of Glasgow. But I'm also, far more importantly than that, the chair of the IMID Forum. I'm very proud of that, I have to tell you. So, as ever, if you want some more information in the paper I'm going to discuss now, please head over to Immune-Mediated Inflammatory Disease Forum website. That's www.imidforum.com. IMID Forum, all one word, IMIDFORUM. So, it's a fabulous website. You'll find slide summary, the actual papers, you'll find abstracts, you'll find discussions, you'll find other podcasts. And it's free for you. So just go there and enjoy all the information that's there. And as ever, we hope it's useful to you. Well, today's discussion is going to focus on only one paper entitled The Efficacy and Safety of upadacitinib for Patients with Immune-Mediated Inflammatory Diseases, a systematic review and meta-analysis. So everything right across the IMID field coming into one place. And it comes from Richai and his colleagues. Well, a little background here. The title's pretty self-explanatory, but the treatment for immune diseases across the board has changed from use of broad-spectrum immune therapies to highly targeted interventions. The biologics led the way, and of course, we've now seen small molecule inhibitors picking up particularly cytokine receptor-mediated transduction, and that has led to potential benefits across a whole range of immune disorders. Now, this particular review focused on upadacitinib, which is an inhibitor of JAK1 and a bit of JAK2. It's been approved for the treatment of atopic dermatitis, psoriatic arthritis, rheumatoid arthritis, axial spondyloarthritis, inflammatory bowel disease, including Crohn's and UC. So it's a pretty broad disposition across the immune disorders. And as such, it's kind of interesting to bring the data sets all together in one place. And that's what this meta-analysis has done. There have been many trials, you can imagine, conducted to look at the efficacy and the safety of upadacitinib in this context. And this was an evaluation of the evidence from a synthesis of randomized controlled trials. And I think has probably given us some insight to guide our clinical decision making. Well, the methodology is a systematic review, meta-analysis. It involves searching PubMed, Web of Science, and Embase from database inception to May 2024. So there's a cutoff point, so that's already more than a year ago, for RCTs of upadacitinib in RA, axSpA, PSA, Crohn's disease, and ulcerative colitis. 2 reviewers screened, extracted data, and assessed for bias using Cochrane tools, and the various outcomes that were evaluated included measures of efficacy and safety. For efficacy, it was remission, disease activity scores, health-related quality of life, and for safety, it was adverse events, serious adverse events, particular focus on infections and on herpes zoster for fairly obvious mechanism-associated reasons. And they were analysed with RevMan STATA using fixed or random effects models, if such things are interesting to you, and they should be. 1,342 full-text articles were assessed for eligibility. 45 studies were included in the RCT synthesis. So, what are the key findings? Well, in RA, upadacitinib 15 milligrams once per day improved ACR20 and DAS, CRP, low disease activity compared with placebo. In axSpA, upadacitinib 15 milligrams once a day led to greater improvements in ASAS20 and 40 compared with control. In PSA, upadacitinib 15 milligrams once a day led to a higher proportion of patients achieving ACR20 compared to placebo. In Crohn's disease, upadacitinib 45 milligrams once a day resulted in a significantly higher proportion of patients achieving SF, APS, CDAI, CR, and endoscopic response compared with placebo or control groups. And in ulcerative colitis, upadacitinib 45 milligrams once a day resulted in a significantly higher proportion of patients achieving complete response, CR, compared with placebo. In terms of safety, upadacitinib was associated with a slight increase in the risk of infection, particularly a higher risk of herpes zoster compared with non-upadacitinib therapeutics. And that confirms a literature that is extensive and very well known to us all. Well, what do we conclude? Well, I think it's not particularly earth-shattering. Upadacitinib is effective in treating immune diseases across the board. It seems generally quite well tolerated, and its safety is, as I think we already know from the long-term extension studies, and quite a large volume of real-world evidence, and particularly when you think about herpes zoster. This is an interesting paper. It brings everything together. Thorough assessment, monitoring, and individualization of dosing is going to be vital. We don't have that flexibility of dosing in labels and license approvals at the moment, and I think that's an area that we need to start to think about in the use of these small molecules. There's probably dose flexibility that we don't have as easily available to us as we have when one thinks about large biologic interventions. But just to be clear, that's not what the labels say we should be doing at the moment. It's an effective way of improving quality of life, improving disease activity, and that's all to do with the ability of upadacitinib to modulate cytokine signaling across the board and therefore bring conferred benefits for our patients. I think it's fair to say that Dr. Chai and his colleagues comment on the heterogeneity shown, and they also comment on variability at the individual level. And I think that's certainly very fair. It's always a huge leap from a meta-analysis to an individual decision. On the other hand, we as physicians have to make our clinical decisions based on the best evidence. So we ultimately are the masters of that individualization. We'd like more data to help us to make that more standardized across the board. And we really do need that further research to clarify the impact at the individual level. Well, look, that's all I've got to talk about today. As it happens, it's a really interesting synthesis, and if you want a one-stop shop to bring all of the different RCT data together, then this is probably for you. So I hope that's been helpful. It's always an absolute joy to have you join me here in the podcast. I hope what we're producing for you on the website and talking about in the podcast is interesting. Most importantly, we're doing this to try and provide better outcomes for our patients, people with immune-mediated inflammatory diseases. And if we can give you that evidence that improves outcomes for our patients, all the better. Thanks ever so much, wherever you are and whoever you are. It's great to have you here. I look forward to seeing you next time round. Bye for now.